And we've reached the witching hour. All right, it's a really great pleasure for me to introduce my good friend Laura Heyneman to you today. Laura's a professor of radiology who spent most of her career at Duke, which is where we were co-fellows. So she and I did abdominal imaging fellowships together. And despite her defecting for ground glass vagaries, later in her career, we've remained dear friends ever since. So it's a really big pleasure for me to have her here. Laura, I had to review her CV, which was, daunting. She attended UNC for med school, Duke for radiology residency, abdominal imaging fellowship with me, and then went out to Vancouver to do her chest fellowship with Nestor Mueller. Then she went back to Duke, where she rose to the rank of full professor within the cardiothoracic imaging division, and where she spent over 22 years.
Who's counting?
She's had faculty appointments also at UNC and Vanderbilt, but she's back at Duke in the position of adjunct professor at the VA. She's had positions such as section chief of cardiothoracic imaging, as well as assistant residency program director, both at Duke and UNC. She has chaired numerous national committees for the American Board of Radiology, Radiologic Society of North America, Society of Thoracic Radiology, and she's a recognized thoracic imager and lecturer in national and international meetings. And she is a content contributor for a variety of educational resources, including StatDX, MRI Online, as well as peer-reviewed articles in thoracic imaging, radiology, and radiographics. Most of all, Laura loves to teach, and she's been awarded numerous institutional and national society awards in recognition of her teaching, including being the recipient of the Duke School of an Excellent in Professionalism Award, which is their highest honor. When Laura isn't staring at ground glass, you can find her outside. She's an avid runner, completing all kinds of masochistic events, including 50K in Croatia recently. So Laura's lecture today is Imaging in Pulmonary Fibrosis, What You Need to Know. Today, we also welcome our colleagues in pulmonary and rheumatology as her subject is relevant to their practice. Thank you so much and welcome to Charlottesville.
Awesome. I am delighted to be here. It is a great time to see Becky as well as other people who I have known and loved over the years. And I will look forward to meeting some of you all in the near future. What Becky did not mention is that she and I laughed our way through our abdominal fellowship, which I did pretty much just to buy time before being able to go above the diaphragm the following year. And when I finished my chest fellowship, that's when I started to hear Becky in her inimitable, self-deprecating way saying, Laura, what do I say with pulmonary fibrosis? It all looks the same. So after all these years, Becky, this one's for you.
Thank you.
I am going to be starting by just talking about what findings on CT tell us that we are dealing with fibrotic lung disease, so that we are all starting on the same page here. I will then focus on what the American Thoracic Society, the European Respiratory Society, how they want us to classify CTs based on the imaging findings, and what the clinical significance of the classification schemes are. This just got updated in 2025, so you'll have your finger on the pulse. And with that update came some controversy. So I will fill you in on a little bit of the controversy, and you can figure out where you want to lie. And then we'll finish up with some additional factors to consider when reporting a CT in someone with pulmonary fibrosis. So we're going to start with a WOTO, stands for working together. And we got two patients here, two different images. Both of these patients have reticular abnormalities on their CTs, linear abnormalities, which tells me that both of these patients have some interstitial abnormality. And the question is, which patient has fibrosis and why? How can you tell on that one image? And then, what does the other person have? So literally, I want you to talk to your neighbors and come up with just like for 30 seconds, maybe a minute, and decide what is it about one image that tells you that they've got fibrosis, and what do you think the other person has? All right. Woto. Probably don't know.
Dial baby. One place I can start. Yeah. Then it's like not.
To answer this question, and we will be answering this question, I promise, we will turn to the cardiothoracic imager's best friend, the secondary pulmonary lobule, which is defined as the smallest unit of lung completely surrounded by interstitium, which means that the borders of the secondary pulmonary lobule, the interlobular septa, are part of the interstitium. And when we look on an electron micrograph, we can see these very regularly spaced linear opacities that put together make up little polygons that are about 1 to 2 centimeters in diameter. Those are the interlobular septa. And it's normal to see 1 or 2 on a CT, but you should not see so many that you are able to form polygons. When you see that, there's too many. They're too thick. And because the interlobular septa contain venules and lymphatics, the things that usually thicken the interlobular septa are either fluid leaking out of the venules or something infiltrating the lymphatics. So edema or lymphangitic carcinomatosis are the 2 most common causes, this being a patient B, who had lymphangitic carcinomatosis. So patient A has fibrosis. And what we see in patient A are more linear opacities, but here they are very, very, very tightly packed and disorganized. They're not regularly spaced through the lungs. And within those fine irregular lines could fit within the confines of a 1 centimeter secondary pulmonary lobule. These are intralobular lines that essentially form the scaffold of the secondary pulmonary lobule. So when you look on the electron micrograph, you see there's really, really fine mesh of interstitium that normally is so small and so fine that you don't see it at all on a CT. But that is what gets thickened with collagen and other changes in fibrosis. So the presence of intralobular lines, that disorganized mesh of fine lines, is the hallmark of fibrosis on CT. There are a couple of things that can fool us and make us think that we're maybe dealing with some intralobular lines that are thickened. The most common mimic is dependent subsegmental atelectasis. So somebody who's lying supine on the CT gantry, the weight of their lungs and their body causes some of the alveoli in the most dependent aspects to collapse and form some fine lines. And it's because of that in someone who's coming in to get evaluated to see if they have pulmonary fibrosis, so on our new ILD protocol, we flip them prone. Because then people, the alveoli that were dependent and collapse, then become anti-dependent and open up. And so those fine lines are transient, they go away on prone imaging. As opposed to somebody else who has some fine lines in the subpleural posterior dependent lung on initial supine CT, when flipped prone, they stay there. So this is a fixed abnormality and tells me that this person likely has early pulmonary fibrosis. There are a bunch of other findings that we see in someone with pulmonary fibrosis that clue us in that would probably, it's like a secondary sign and is further evidence, confirmatory evidence that we're probably dealing with somebody with pulmonary fibrosis. So it is very, very common to see ground glass associated with those fine lines, that mesh of fine lines. Ground glass, if you think of like what causes ground glass on CT, one of two things in my mind. Either it's partial alveolar filling, so you got some air and you've got something else filling the alveoli, and in the setting of fibrosis, it's often inflammatory cells that are partially filling the alveoli, but it's also causing ground glass is a super fine interstitial abnormality that is so small that we can't see it on CT. And so it just shows up as an area of increased density. So ground glass that is associated with those fine lines, very, very common to see them both together. You usually see volume loss in somebody who has fibrotic lung disease as things are retracting. And it's always a good idea to look, I think it's helpful on coronal or sagittal reformats in particular. Is the volume loss just concentrated in one area of the lung, or is it diffuse? And like the overall lung volumes are low. That'll come into play in a few minutes when we start talking about some of these different categories that the American Thoracic Society wants us to use. Other associated factors, so if we go back to our friendly electron micrograph, you see in the middle of the secondary lobule, there is a terminal bronchiole and an arteriole. So those are the centrilobular entities. And if you get thickening of those intralobular lines, pretty understandable that you can then pull on that centrilobular bronchiole and you will get bronchiolectasis. So very common to see bronchiolectasis associated with the fine irregular reticulation. And lets me know that the bronchioles are being pulled open by something that is fibrotic. You can get bronchiolectasis from things other than fibrosis, but when you see bronchioles within the distal centimeter of the lung, they should be too small to see at that point. So when you can see bronchioles that far distally, they're dilated. And when those dilated bronchioles are within an area of reticulation, then it tells me, okay, it's likely being pulled open by fibrosis as opposed to being dilated for some other cause. We also sometimes see honeycombing as a finding in really end-stage fibrosis. And pathologically, honeycombing is collapse and distortion of fibrotic alveoli and alveolar ducts, and often associated collapse and distortion of bronchioles. So what we see on CT is well-defined cystic lucencies, tend to be pretty uniform in size. and tend to be pretty small, less than a centimeter, and they are stacked one on top of one another with no intervening lung, because this is all fibrosis that has progressed to the degree that everything is distorted and collapsed down on one another. So you get these cystic lucencies stacked upon cystic lucencies with no lung going in between. And I call honeycombing tight. I spend some time trying to make sure that what I'm calling honeycombing actually is honeycombing. And that is because the presence of honeycombing denotes a progressive fibrosis. It is a progressive process, with this being the end stage. And the mortality for any form of progressive fibrosis is pretty high. So the presence of honeycombing carries a prognostic information. And as you'll see in a few minutes, it also carries some diagnostic information. So that I call it tight, and I spend some time looking to make sure that these well-defined cystic lucencies are truly stacked up on one another without any intervening lung. Usually it's subpleural. It can be occasionally peribronchovascular. You will see in a minute when we start talking about some specific diseases. It's a common finding in the fibrosis called usual interstitial pneumonia, UIP, but it can be seen in other end-stage fibrosis. So it can be seen in sarcoid, it can be seen in fibrotic hypersensitivity pneumonitis. There are other disease processes as well. So when I see lucencies in the midst of some reticulation, I do spend some time and, ask myself, are these lucencies separated by a little isthmus of lung? It's not going to be normal lung probably, but is there a little lung in between them? Which in this particular case, circled right there, that's bronchiolectasis. Or are the lucencies stacked up on one another and there's no lung in between, which is honeycombing. And because honeycombing is end stage of a progressive fibrosis, where you get distortion of alveolar ducts and bronchioles, you often see both bronchiolectasis and honeycombing in the same patient in the same image. But again, I spend some time, because if honeycombing is not present, I don't want to call it. There are a few things that can mimic honeycombing. And I spend some time making sure I'm not getting fooled. So significant bronchiectasis can potentially look like honeycombing, where saccular bronchiectasis, that's cystic lucencies that got well-defined walls because they're the bronchial walls. And it is possible for that to fool people, fool me. So I find, just as a little hint, I guess, that going to MNIPS can help a lot. Because with MNIPS, you can tell often that the cystic lucencies are connected to one another, branching, or you can tell whether they are discrete from the more central bronchi and don't seem to connect. And so that has saved me a couple of times from calling honeycomb. Another thing that can potentially mimic honeycombing, because they are both subpleural, is paraseptal emphysema. So paraseptal emphysema tends to be subpleural, one layer thick, with a very thin wall. The wall is actually the interlobular septa. Whereas honeycombing, the wall is a little bit thicker, a little more well-defined, and again, stacked. So not just one layer thick. And the cystic lucencies tend to be smaller. So paraceptal emphysema essentially is involving the secondary pulmonary lobules. So those are 1 to 2 centimeters separated, the septa. Whereas honeycombing, it's much more, the lucencies are much smaller. Okay, so those are the ground rules, what we're looking for to determine that somebody's got fibrosis. So then the question becomes like, what do we say to answer Becky's question? What do we say? So the American Thoracic Society, the European Respiratory Society, the Japanese Respiratory Society, a bunch of societies got together and they agreed on how we should classify CT scans in which a patient has fibrotic lung disease. So here's case number 1. And we'll talk about that. So I'll just let this scroll through a couple of times. And you can think to yourself, what are the findings that you see? And then you may or may not know what to do with those findings. But that's why I'm here. So, and here is just a single image of the coronal, which again, I find when we are looking at pulmonary fibrosis, super helpful to look at coronals and sagittals to determine distribution. So to answer this question, like, what are we going to say? Again, various societies got together first in 2022, again, just last year in 2025, and came up with guidelines and told us that essentially in our impression of pulmonary fibrosis, we should say one of the following. This is a usual interstitial pneumonia pattern. This is a pattern of probable UIP. This is a non-UIP pattern that has an alternative diagnosis of blank, or this is indeterminate for UIP. So UIP is clearly an important entity to know about since every one of those criteria mentions it. So UIP is the most common fibrosis. It tends to occur in older individuals, usually greater than 65 years of age. And pathologically, when a pathologist is looking at a little square of tissue in someone with UIP, one of the hallmarks is temporal heterogeneity. It is as if the lung is kind of constantly getting injured. And so there is some normal lung, there is some acute inflammatory response, and there is some burned out fibrosis, all within the same little square of tissue. There are other things that they look for as well. Fibroblast foci are part of the acute inflammatory response, and it looks like that. Oh yeah, I'm believing them. But so temporal heterogeneity is one of the keys of usual interstitial pneumonia. And again, it is the most common. It is associated with a whole host of things. There are a gazillion medications that can lead to usual interstitial pneumonia. There are several connective tissue disorders that are associated with UIP. Rheumatoid arthritis being the most common. UIP is the most common type of fibrosis in somebody who has rheumatoid arthritis. Asbestosis is fibrosis with asbestos fibers in the middle of it from prior asbestos exposure. And it's only after they have excluded any cause that this is referred to as idiopathic pulmonary fibrosis, IPF. And we are really, really good at making the diagnosis of UIP when there is a classic UIP pattern on CT. And I'll tell you exactly what the classic UIP pattern is in just 1 second. But we are so good, positive predictor value around 95%, that when we see it, the patients will not go to biopsy. So they will essentially be given the diagnosis of UIP. And it carries with it a pretty dire prognosis. There's a 80% 5-year mortality. And so, patients who hear that they have UIP will go to Google and will see that they have a pretty dreadful prognosis. Recently, there are antifibrotics that have slowed the rate of progression. But those antifibrotics are really expensive, like thousands of dollars a month, potentially. So I don't want to be giving a person a UIP pattern unless I'm pretty confident that they have UIP. So what is a classic UIP pattern on CT where we are so good at making the diagnosis? So you have the irregular reticulation, that is the thickened interlobular lines, and it just going to tell, that's part of fibrosis. It is subpleural, basilar predominant with subpleural honeycomb. And there are no features that are incompatible with UIP. There are no non-UIP features. So what are those? There are a bunch of them. But mostly, so if there is, instead of a basilar predominance, if there is a mid to upper lung predominance, if instead of things being subpleural, so it should just literally go all the way up to the costal margin. There should be no spared lung between the abnormalities and the costal margin. If it's subpleural sparing, that's a non-UIP feature. If instead of being subpleural, it is peribronchovascular in distribution, it is a non-UIP feature. I've already said that ground glass is really common with reticulation, but if you have a lot of ground glass without the reticular opacities, that is a non-UIP feature, as is a lot of consolidation. The presence of nodules being a dominant feature, that's non-UIP. And the presence of extensive air trapping, which they define as in 3 or more lobes. So the person doesn't have that, but they have basilar predominant subpleural honeycombing, then that is someone who has has pulmonary fibrosis in a UIP pattern, and that is what my impression will be in this case. What about here? What do we think here? Let this scroll through a couple of times. So here we again see irregular reticulation. Bunch of fine lines fit within the confines of a secondary pulmonary. And it is subpleural. It goes all the way out to the costal margin. It is only in the subpleural region. It seemed to be getting worse as we went down. And there weren't any nodules, air cysts, consolidation, anything that would be a non-UIP feature. But there's no honeycombing. So this is essentially a UIP pattern without the honeycombing. Basilar predominant, reticular opacities with associated bronchiectasis, nothing that's not compatible with UIP. So this is a probable UIP pattern. And we're pretty good when we make that diagnosis. So we have a positive predictive value of 80 to 85%, which means that 15 to 20% don't actually have UIP. But usually that 15 to 20% clinically has something off. And usually often that's because they're younger than they would expect for UIP. So most places, if a probable UIP pattern is called, that person will not go to biopsy, assuming that clinically there's nothing that raises an antenna, and will be given a diagnosis of UIP. So, though, again, I want to be calling things pretty tight. I don't want to be calling a UIP or a probable UIP pattern unless I'm feeling pretty sure about it. Okay, another minute WOTO. So what would you say here? I'm going to tell you that there's some non-UIP features, just based on the fact we've gotten to that portion of the talk. So talk amongst yourselves for 30 seconds, a minute. What are the non-UIP features? And if you know, what do you think it is?
That's scary. Yeah, it seems like I was. Yeah, I was thinking.
Buddy. Chief President here in the middle. Going on you. What were some non-UIP features that you think might be present in this case?
Well, there's like more ground glass and like it seems like maybe some air trapping, perhaps. It's not fully subpleural.
All right. So there is a lot. So I will say it does seem to be getting worse as we go down. Like that sagittal, it's like basilar predominant, I would say. And there is bronchiectasis, I would say, as well as probably some regions of bronchiolectasis. A little bit of reticulation, but not a whole lot. There is a lot of ground glass here without reticulation. So that's one non-UIP feature. And as you said, there are some aspects, there are some aspects in which there is subpleural sparing. It does not go all the way out to the costal margin. So these are features that are strongly suggestive of a diagnosis of fibrotic non-specific interstitial pneumonia, NSIP. So NSIP, pathologically, unlike UIP, which had that temporal heterogeneity, NSIP is if the lung gets hit with an injury at one moment in time and heals from there. So it's very homogeneous and uniform. So you can have a spectrum of abnormalities with NSIP. You can get hit and have a relatively acute inflammatory form of NSIP, what's referred to as cellular NSIP, which tends to give you a lot of ground glass without really any reticulation. And there's going to be a very broad differential for that. Or you can develop fibrosis from that injury, in which you have more reticulation, traction bronchiectasis, some bronchiolectasis, but there will not be any honeycombing, or there will be minimal honeycombing with pure fibrotic NSIP. The pathology, the fibrosis, tends to start in the peribronchial region, which is why you get a lot of traction bronchiectasis in people who have fibrotic NSIP. It tends to be a really prominent finding because that's where the fibrosis tends to start. So because of that, sometimes it's pretty obvious that it is peribronchial in distribution, but not always. So NSIP has a pretty variable appearance. It can be pretty uniform, or it can be peribronchial. The subpleural sparing that we saw is pretty specific to fibrotic NSIP, but it's not very sensitive. So you can have fibrotic NSIP without the subpleural sparing. If you see it, that's probably what it is. So as a result, NSIP can, if you're putting this into one of those ATS criteria, if you see parabronchivascular distribution with subpleural sparing, then I would say this is an alternative, a non-UIP pattern that's with an alternative diagnosis of fibrotic NSIP. But if I see basilar predominant reticulation with ground glass, no subpleural sparing, no honeycombing, then it could potentially be a probable UIP pattern. And it's for those people, that's a lot of the 15 to 20% who get biopsied who don't have UIP on the probable UIP category. People with NSIP tend to be younger. And there is a very strong association with collagen vascular, with connective tissue disorders. So that, you know, if anybody's taking a multiple choice test in the near future, or in real life, when you are looking at scans, look at the esophagus, because it often will be patulous from scleroderma or one of the mixed connective tissue disorders. Okie doke. I will let you think about this for 1 second. Don't have to WOTA, you can't. But 3 different axial images, sagittal image. What's your impression here? What are the non-UIP features, perhaps? So here we have a bunch of findings. There's definitely irregular reticulation with some bronchiectasis. I think we see that, you know, up here in the left upper lobe. But instead of being basilar predominant, it's pretty much everywhere. There's no zonal predominance from a cephalocaudal standpoint, nor would I say is there a predominance from an axial subpleural distribution. It's pretty diffuse everywhere. There is a lot of ground glass without necessarily not necessarily in areas of reticulation. So that's going to be a non-UIP feature. And within the ground, in addition to the ground glass, there's some areas that seem pretty normal in attenuation, but then there are some areas that seem particularly low in attenuation. So you got some normal lung, some ground glass, some regions of low attenuation, hyperlucency, which on expiratory phase imaging, those areas that were hyperlucent stay hyperlucent and are even more accentuated because there the rest of the lung seems to be gaining some density. So the rest of the lung is able to become a little atelectatic. These areas are not. Those are areas of air trapping. I noticed that a lot of them are very polygonal and look lobular in distribution. So these, the air trapping, the ground glass, the lack of zonal predominance are all non-UIP features that are typical for fibrotic hypersensitivity pneumonitis. So hypersensitivity pneumonitis, you breathe in an antigen, you get an immune reaction. Well, you don't. I'm sure you don't. One does. There's an immune reaction, and there are peribronchiolar granulomas that form. And it's because that granulomatous response is around the bronchioles that you get lobular air trapping. Causes trapping of the bronchiole, of the terminal bronchiole and the lobule associated with it. This factor that there's normal lung, there's ground glass, and there's hyperlucency. That is referred to as a 3-density sign, formerly known as a head cheese sign. Nobody knows what head cheese is, so they just stopped using that. And it is typical to see, particularly in fibrotic hypersensitivity pneumonitis, But you can see it even before the fibrosis develops. So with hypersensitivity pneumonitis, it starts off non-fibrotic. You get this immune reaction. There are often a bunch of ground glass central lobular nodules as the immune reaction is filling up the secondary pulmonary lobule. But if you take away the antigen, in general, it can get better. But once you start to develop reticulation and signs of fibrosis, then this inflammatory cascade has essentially been tipped over, and then it will often progress even if you remove the antigen. So this person had a bunch of pet birds, which eventually she was convinced to give away. But despite her no longer having birds, her fibrosis progressed over time. And again, you can develop honeycombing in the setting of fibrotic HP. And I mention that because then it tells the pulmonologists and the clinicians that this is definitely going to progress further, and it often changes management. Now, here's part of the controversy with the latest iteration of the ATS criteria. The ATS says that instead of talking about hypersensitivity pneumonitis, we should be referring to bronchiolocentric interstitial pneumonia, BIP. So HP, out the window, BIP. Because they say that a substantial percentage of people who have that 3 density sign and signs of fibrosis, when biopsied, actually turn out to have something other than fibrotic HP. Usually a connective tissue disorder or aspiration, chronic aspiration. And that the diagnosis of fibrotic HP is something that can only be made with a known exposure or at a multidisciplinary conference. It is not something that we should be talking about on CT. That was so controversial that some of the people who initially wrote the classification decided not to include their names on this paper. So David Lynch is a big name in interstitial lung disease, and he is not on this paper because he doesn't think that we should be making that change. So you can decide. You would be in very good company either way you go. And perhaps, you could take your lead from the pulmonologists, the ILD docs at your institution, which I'm sure you'll all stay here and they will be here, but you never know wherever you go. So, all right. One more case here. This is another person who has signs of fibrosis. We see traction bronchiectasis, bronchiolectasis, some reticulation. What do we think here? And I thought I was given an hour, so I apologize. This is going to go over a few minutes, but I'm going as fast as I can. So here we have, I think on the coronals, you can see it is upper lobe predominant process. That is central. So if you look on the coronals, it seems like most of the fibrosis, the traction bronchiectasis, bronchiolectasis is actually in the relatively perihilar regions. And there are a bunch of nodules. So those are non-UIP features and are fairly characteristic for sarcoid. End-stage sarcoid, fibrotic sarcoid. So this is the beautiful Heyneman scheme of where the lymphatics are in the lungs. So there are a lot of lymphatics in the peribronchovascular interstitium. So a lot in the hyla, a lot along the bronchovascular bundles. There are lymphatics in the subpleural lung, and there are lymphatics along the interlobular septa. Sarcoid granulomas deposit along the lymphatic. So that is why you see a lot of perihilar, subpleural, peribronchovascular nodularity that then can develop into fibrosis. And it turns out that there's less lymphatic drainage in the upper lobe, particularly the posterior upper lobe, which is why there tends to be an upper lobe predominant process. And we can see honeycombing in sarcoid. So again, the presence of honeycombing does not denote UIP. You can see it in some other entities as well. You can occasionally even see some prominent air trapping in sarcoid because the peribronchiolar granulomas can cause some lobular air trapping. All right, what about here? Just 3 images, so you're just going to have to take my word for it. But here, we definitely have some fine irregular reticulation. But it doesn't seem any worse than one from a cephalocaudal standpoint. There's no zonal predominance. And some of it is definitely subpleural, but there's some areas where it seems like it's peribronchovascular. There's no honeycombing. And, you know, this is not clearly one of the entities that I outlined. And there are other entities, you know, that we can be able to say, oh, I know what this is. Couldn't go through all of them. But this case doesn't have any of them. So I don't know what this is. So this is a pattern that is indeterminate for UIP. And usually those people go to biopsy to get a diagnosis. And about 20% will have UIP. So there are a sizable number of people who have UIP that presents as a sort of in an atypical way. But because of the importance of trying to determine, is this UIP or not? Is there a specific diagnosis? These people generally go on to biopsy. Sometimes they go on to bronchoscopy before biopsy. There's certain things in a bronchoalveolar lavage and lymphocytosis that helps pulmonologists think about HP, for example, or BIP, wherever you want to fall on that list. But a lot of times they go to biopsy. So this is what you should put in your report. In my impression, pulmonary fibrosis in a UIP pattern, a probable UIP pattern, a non-UIP pattern of blah, and a pattern indeterminate for UIP. So what else to include? What else should Becky be looking for? So I've already said, look at the esophagus, because that ups your chance that you might be dealing with somebody with a connective tissue disorder if you have a patulous esophagus. I will tell you, I am not a big fan as a thoracic imager of amiodarone. It has a gazillion thoracic toxicities. I shouldn't say, I hope, sorry, cardiologists. So if somebody has evidence of a pacemaker, then I look in Epic or whatever your electronic medical record is to see whether they're on amiodarone or have been, because that is potentially something to consider. Bony changes of RA, various, look for potential cause. There are other findings that can point to a potential cause, specifically connective tissue disorders. So if there is exuberant honeycombing, so that if most of the fibrosis is honeycombing, greater than 70% of what is there is honeycombing, that is associated with rheumatoid arthritis in particular, related UIP. A straight edge sign, where you have fibrosis that on coronal or sagittal reformats just seems to end, and it doesn't get extended further up. That is also associated with connective tissue disorders, most commonly rheumatoid arthritis-related UIP. And the anterior upper lobe sign, which means that the majority of the fibrosis in the upper lobes is in the anterior lung. Doesn't mean that you can't have any fibrosis in the posterior lung, but if the majority is in the anterior lung, that is a finding that is also suggestive of a connective tissue related ILD. I think out of the three, this is the least specific. So these are relatively specific, particularly the straight edge sign and the exuberant honeycombing sign. They're not very sensitive. So their absence doesn't rule it out. But, you know, suggesting it can potentially help with patient management. Also associated with fibrosis is cigarette smoking. There are a gazillion interstitial lung diseases that are associated with cigarette smoking. And now that I work at the VA, I know about all sorts of things I didn't know about before. So there is very common to see emphysema, what's clearly a smoking related, you know, process with fibrosis. Another little change, just to keep you, you know, finger on the pulse, is that desquamative interstitial pneumonia, which is a smoking related, often smoking related, doesn't have to be, interstitial process has been renamed alveolar macrophage pneumonia, AMP. But so it's very common to see emphysema. And the ATS et al. Have asked that we essentially dictate whether there's emphysema with a UIP pattern or emphysema with a non-UIP pattern, because it can affect patient management. Other things to look for, really important. If you have priors, has it changed? Has it gotten worse? Is there an increase in extent of the reticular opacity? Is there development of bronchiectasis where there didn't used to be? Is there development of honeycombing where there didn't used to be? That indicates a progressive fibrosis, which again may trigger antifibrotic therapy, which brings with it some side effects, which are also financial side effects potentially. So is there progression? Is there a change over a very short period of time? So most of these fibrotic processes, the progressive fibroses, trudge along slowly over time. And, you know, the antifibrotics can slow the progression, but don't usually stop the progression. But occasionally, there is just an acute downward trend with a patient becoming markedly more symptomatic in a short period of time, like a month, few weeks. That is a process called an acute exacerbation, which essentially pathologically is diffuse alveolar damage. And those patients have a very high mortality in a short period of, in the short period of time. You do need to exclude an atypical infection, pneumocystis, for example, that gives you a bunch of ground glass, COVID. But just be aware if that is something that you see, is the development of a lot of ground glass, often with associated reticulation, because DAD progresses pretty quickly to a form of mild fibrosis. They have stiff lungs, so they pop an alveolus, and you can develop pneumomediastinum if they pop an alveolus into the adjacent peribronchiovascular interstitium. You can pop an alveolus into the pleural space and get a pneumothorax. Super common to see pneumomediastinum just incidentally in somebody who comes in for routine follow-up. And lung cancer. very high risk of lung cancer. Anybody who's got chronic lung disease is at increased risk for lung cancer. Certainly, if they have a smoking-related fibrosis, ups their chances further. So be aware that any sort of development of focal consolidation, you need to follow it up to be sure that it goes away. Because of all of the distortion, cancers don't really look like a sphere necessarily. It's just sort of a region of focal consolidation sometimes. So be sure to get a short-term follow-up so that you can then determine whether to further, sample, PET, the whole shebang. And then finally, I think, people with fibrosis are at risk for developing cor pulmonale. So I look for signs of right ventricular hypertrophy if it is a contrast enhanced CT that I'm looking at. Big central pulmonary arteries. If there is, again, contrast on board and you can see whether there is straightening of the interventricular septum, signs of increased pressures within the right ventricle. Okay, so that's your report. It then goes to the clinical team, and at a lot of institutions, I'm assuming here, I didn't Google it to know for sure, but I'm assuming you have an ILD multidisciplinary conference. And multidisciplinary is usually pathology, radiology, pulmonology, rheumatology sometimes comes, surgery sometimes comes. And really the question becomes, is the CT findings, are they diagnostic? Can we stop here and just go with the CT impression? Or do we need to do a bronch or biopsy to know for sure? UIP, probable UIP pattern, most of the time, those people do not get biopsy. If it is so clearly sarcoid, then it's sarcoid usually. There are certain things that people feel comfortable just calling based on the CT findings. All right, so that takes us to the end. These are the 4 patterns. The presence of intralobular lines, particularly when you see associated bronchiectasis, but think fibrosis. I will say, I am leaving you with a parting gift. Everybody needs a fibrosis playlist. So I think I listened to them all and there's nothing too, obscene or anything. So if anybody wants the fibrosis playlist. And this is the most recent iteration of ATS. And thank you very much.